impressed at how many people have stuck it out till the bitter end. Please make sure you leave your audience response device here. Don't take it with you. And we would appreciate your filling out the evaluation online as soon as you get home so that we can see the results and so that it's still fresh in your mind. So we talked in a number of venues about viral infections. We've talked in the transplant section. We've talked in the pneumonia section. Tom mentioned encephalitis a little bit. So what I really want to focus on are really two issues. One is respiratory viruses, and the other is herpes viruses, which can either cause encephalitis in the case of simplex or other diseases in the case of CMV and VZV. In terms of respiratory tract pathogens, I think you all realize that there are lots of different respiratory viruses, but the only one that we can really treat is influenza. And as Anthony mentioned, we do have some drugs for RSV. But influenza is really the one to focus on because that's treatable. So again, when somebody presents with an X-ray like this, you really don't know until you do your rapid tests and your cultures what viral disease or what cause of pulmonary infection you really have. So the question is, first question is, a 35-year-old male in good health developed a cough, fever, and shortness of breath in February of 2009. He's admitted to the ICU with diffuse infiltration and hypoxemia. His rapid flu test is positive, which would actually only happen in a small percentage of cases. Which of the following has been demonstrated to be effective to treat pneumonia due to influenza virus? So let's look at this and start the timer. All right, Anthony made this point so that the correct answer is D. I think some of you were fooled about A in that Tamiflu or oseltamivir is effective for treating influenza syndrome, the upper respiratory infection. The point is that once you have pneumonia due to influenza, there's nothing that's known to be effective. Now, like all of you, I would treat influenza pneumonia with a drug that's active against influenza. We'll talk a little bit about oral oseltamivir versus inhalational zanamivir versus IV peramivir. There are different routes. It may be that those drugs have potency in that order. Oseltamivir, moderate, zanamivir more, peramivir the most, but there's no evidence that any of them will change the course of an influenza pneumonia. So, influenza, again, Anthony mentioned, but when we talk about treatment of influenza, this is an update of the map that is in your handout. You're all aware of the fact that influenza subtypes change. And the point here is that depending on where your patient has been, the type of influenza is going to be different. Now, in 2010, most of the influenza that was seen worldwide was the epidemic strain of H1N1. But without going into great detail, there is H3N2, there's the seasonal H1N1, there's influenza B. The susceptibility is going to differ. So before you treat influenza, you need to look up on the website or talk to your ID people or look up somewhere what is the strain that is circulating in that month and what is the susceptibility. Because I think in 2010, 2011, we're going to see a lot of changes. And I don't think we can predict that what we saw in 2010, where oseltamivir, Tamiflu, was effective in almost everybody in terms of in vitro activity. I don't think that necessarily is true later. But again, very effective if you started early for influenza syndrome, might be effective, but no evidence that it's effective in pneumonia. So the drugs for influenza are Tamiflu or oseltamivir, very well tolerated, other than the fact that people get nauseated. The neuropsychiatric issues, I think, are not really relevant. It was mostly in children, mostly in Japan. Nobody's ever explained why there were these psychotic reactions in Japan. It was the same product. Tom Bleck might have some perspective on that. But oseltamivir is very well tolerated. You have to take it within the first few hours to really be effective. You can take it up to 48 hours, but the longer you wait, the less effective it is. When your patient's in the ICU, your choices are really zanamivir, which can only be given inhaled, and that causes bronchospasm, so that's almost always a concern, Or if you want to give IV, there is an IV Tamiflu and IV Zanamivir that are under investigational use. Peramivir is available. You can get that through the manufacturer, and that does appear to be a well-tolerated active drug, but hospitals don't keep this in stock. So, again, for the influenza syndrome in 2010, Tamiflu, inhalational zanamivir, or IV peramivir were all effective. And again, for other kinds like H1N1 seasonal, a different thing, Tamiflu is not effective. So know what to round. Again, for influenza and pneumonia, nothing's effective. Now, this question: a 35-year-old male is 6 weeks post-stem cell transplant for AML. He's admitted to the ICU with respiratory failure after 2 days of fever and cough. A rapid RSV test on nasopharyngeal wash was positive. Now, you're fortunate in these two cases in that two unlikely events have happened. One was in the first case the rapid test was positive. Usually it won't be. So rapid tests are not good for ruling out disease. They're only good for ruling it in. And RSV in adults is not a good test, but here it happens to be positive. So which of the following has been shown to be effective for this patient's RSV pneumonia? I won't do this as a test, but this is the same trick question as before. It's not what do you use, it's what's been shown to be effective. And the fact is nothing's been shown to be effective. So for RSV, nothing's been shown to be effective. Anthony showed you some data on aerosol ribavirin and palivizumab. Because you showed you that data, I won't go into that before you showed you about the toxicity and teratogenicity of ribavirin. But if you're going to give ribavirin, you have to give that as an aerosol. It causes bronchospasm. It's not easy to give. It's not easy to give on a ventilator. There are issues about it crystallizing on some of the valves. And again, with RSV pneumonia, which in adults is almost always seen in stem cell transplants or other heavily immunosuppressed patients, you should use it, you will use it. Just be aware of the fact that it is teratogenic. Pregnant nurses can't go in the room. Pregnant people can't go in the room. And it is not clearly effective. Even the enthusiasm in neonates with RSV pneumonia, I think, has waned. So aerosol ribavirin, uncertain efficacy. There's the dose that was also in Anthony's handout, and the toxicities are hemolytic anemia, although that's more likely when you're using the oral drug with hepatitis C, bronchospasm, and again, teratogenicity. Now let's change to herpes viruses. So you know a little bit about influenza, you know about RSV. What are the drugs you need to know about herpes viruses? What are the herpes viruses you're going to see? In the ICU, you're going to see herpes simplex encephalitis. Unfortunately, herpes simplex that causes encephalitis is virtually always sensitive to acyclovir, whereas you may see resistant herpes simplex in immunosuppressed patients who have cutaneous disease or once in a while disseminated disease. The encephalitis is almost always sensitive to this reactivated virus. You may also see either localized varicella zoster, shingles, occurring in your patients who are stressed. That's not a life-threatening disease, but you have to know something about it. And then you may see disseminated zoster. You may see CMV in your immunosuppressed patients. So those are the herpes viruses we're really focusing on. The other viruses here in white are really either infrequent or therapy isn't effective. You don't have to know as much about it. So in this course, we really didn't talk much about encephalitis, but obviously when you get somebody who has encephalitis as opposed to meningitis, when they have cognitive impairment and fever, abnormal spinal fluid, the one treatable cause in this country is HSV. So you always want to treat somebody with a clinical syndrome of encephalitis for HSV until you get your testing back. And you probably want to get a test not just when they first present, but another test several days later, just to be sure that the PCR for HSV is negative. So always treat for herpes encephalitis. Actually, we'll get back to this in a minute. So, again, we won't do this as a question. The drug of choice for herpes simplex encephalitis for a 20-year-old is acyclovir alone. Steroids are not necessary, whereas the other drugs there may be active. Acyclovir is clearly better tolerated. Other than some neuroagitation, perhaps seizures with very high doses. Acyclovir is extremely well tolerated, so that is the drug of choice. Make sure that you look up the dose, because the dose you use for encephalitis is 10 milligrams per kilogram 3 times a day or 30 milligrams per kilogram a day. It is not the 5 milligrams TID you'd use for localized simplex. So for any kind of encephalitis, make sure you think herpes simplex and treat for that. So the parenteral drugs for HSV and then for VZV are acyclovir, and again, there's actually it should be 10 milligram. I left off the TID. And again, toxicity is rare. I guess renal crystallization in addition to neuroexcitation is important. Resistance, again, very uncommon with encephalitis. Now, what about zoster? You will see zoster in one of two forms. You will either see localized zoster, and then again, it's an issue of trying to reduce the likelihood that your patient who's in the ICU for other problems will have either short-term or long-term pain, and you will see disseminated zoster. There are some other unusual manifestations of zoster where patients will have neurologic complications or ophthalmologic complications. I think at this course we don't have time to focus on that. But keep in mind that if your patient has zoster, most of the patients are going to be more than 50, although you can see it in younger patients, especially if they're immunosuppressed. And the therapy is famciclovir or valacyclovir. They can take oral agents. In the ICU, you're going to be giving them IV acyclovir. And then prednisone, although not everybody agrees, I think that Rich Whitley and other experts would maintain that if you combine prednisone with acyclovir, you will improve the quality of life and reduce the area under the curve for pain in the long term. Now, again, this is controversial. You look this up and up to date, they waffle a little bit. But I think that if reducing pain is your goal and your patient can tolerate prednisone, I think that most of the real experts would recommend that you use prednisone in addition to your antiviral. Again, just keep in mind that the pain in a small number of people can really be dramatic. So while you're trying to save the patient's life, trying to reduce the long-term pain of herpes zoster is also important. So simplex encephalitis, localized zoster, then in your patients with disseminated zoster, IV acyclovir is almost always going to be the drug of choice. So the last virus we're going to talk about is CMV. The CMV that you see in the ICU is almost exclusively going to be immunosuppressed patients. Yes, there's CMV hepatitis. Yes, there's some other unusual CMVs. But unless your patient is a transplant, or unless your patient has HIV, or unless your patient is on some very immunosuppressive monoclonal antibody, you're not going to see significant disease due to CMV. So mostly what you're going to see is CMV retinitis and encephalitis in patients with HIV, and CMV pneumonitis or colitis in patients with transplants. The drug you need to know there is either ganciclovir or foscarnet. Rick Childs went into that with ganciclovir. Just keep in mind that this is a major marrow suppressive, so I think it is in many ways the easiest drug to use. It is a marrow suppressant, so for many of the patients you're managing with your oncologist or hematologist, they will not want to use ganciclovir. So your other two choices, and these are good against CMV, they're also good against VZV or HSV, although we rarely use it unless we have a known resistant virus because of their toxicity, are either foscarnet, which is quite nephrotoxic, particularly in terms of causing magnesium and calcium wasting due to tubular toxicity. They cause seizures. They cause hypocalcemia and hypomagnesemia, both by causing tubular wasting and by causing chelation. And there are also some unusual syndromes where they cause mucosal ulcers in the genitals. So foscarnet is a good alternative. As Rich said, you will want to use it in your transplant patients because the transplanters won't want to use ganciclovir, but foscarnet, although effective, is quite a toxic drug. And I think cidovovir is something just to keep in back of your mind. It is not a good ICU drug because, number one, it has a very long half-life. It has a half-life of at least a week. So for outpatient regimens, it's fine. for inpatient is both toxic, like foscarnet, has a lot of nephrotoxicity. It also causes neutropenia, but it is something sometimes in a desperate situation, so you're going to use it. We've talked a little bit in our immunosuppressed patient populations about adenovirus, BK, and some of the other influenza viruses like parainfluenza. There's no therapy that you need to know about that's active there. Probably none of them work. Your infectious disease people will come up with some cocktails for them. But for the boards, I would focus really on respiratory viruses, namely influenza and RSV, and herpes viruses, namely simplex for encephalitis or CMV with foscarnet or ganciclovir for immunosuppressed patients. So with that, I'd like to bring the course to a close. Again, we admire those who have sat through and stayed awake for 4.5 days. We hope that this been good as either a general review or as preparation for the boards, but we really will hope that you will fill out your evaluations so that we can try to improve the course. The course, I think, has been gradually improved over the years, but it's really because we have a great faculty and because we get good input from all of you. So thanks very much and have a great trip home.